And then here in the next slide, you can see the calcium scoring meets the criteria for many of the criteria for a useful test. And these are just the Kaplan-Meier curves of the MESA study and the Framingham study. You can see that the event rate was generally higher in the MESA study, which I think reflected, at least in part, an ethnic-specific increased risk. But if you look at the calcium scoring greater than 300, you can see at the 3.8-year follow-up that it was around 9%, 8.5%. But if you look at the bottom, you can see that from the cardiovascular health study, an elevated calcium score was associated with a 2 to 4 times rate of MACE in patients who've already experienced a coronary heart disease event, so they're at higher risk than prior MI. And then if you go to the next slide, you can see these are the 4 criteria that the calcium does not meet the criteria of a useful test, that we generally screen people with a low prevalence of disease. We don't know how to treat them per se. We don't know whether or not that treatment improves their outcomes, and we don't know whether or not that treatment is more effective when applied before the symptoms begin. So I think that any coronary calcium outcomes trial really needs to meet these 4 criteria in order for us to get to all 10. So if you go to the next slide, what are the difficulties of a coronary calcium outcomes trial? I'm sure you guys have reviewed the Phil Greenland proposal for the VIEW trial. The problem is that I think there's four issues with that. The first is that there's a very low rate of adverse events, and that, as reflected in Phil's design, results in an inordinately high sample size. The second is that there's a perception, I think, amongst society and healthcare insurers that they don't want to pay for additional testing. They don't like it. Even if it's a $50 calcium score, they perceive it as adding to the overall healthcare cost, whether it's cost effective or not. There is that sort of possibly erroneous perception. The other thing is that despite the fact that we've tried to educate people that the radiation exposure for calcium scoring is, extremely low, I think there's still a public perception, and even amongst our cardiology colleagues, that it's perceived as unsafe and that conferring additional radiation to people is a bad thing. And then the fourth, and perhaps the most important thing is, we don't know what to randomize patients to in order to effectively perform an outcomes trial. And so we don't know what the treatment differences should be for those with versus without coronary calcium. And there are limited approaches to identifying these treatment differences. So if you go to the next slide, it says, is there a population which mitigates these limitations, i.e. that fulfills the criteria, those 4 criteria, where you have high event rates that can reduce your overall sample size, where you don't need to do any additional testing, so that perception of increased costs will go away. And hence, if you don't do additional testing, you don't add for any radiation exposure. And then I think most importantly that you can find clear and rational differences in treatments between the groups who are randomized. So then the next slide is there a population which mitigates these limitations? And at Cornell in 2005, there were 2 radiologists who kept pushing this concept of early lung cancer screening, and were generally thought of as sort of heretics in the field. However, they were validated by what's on the right, which is the New England Journal of Medicine publication using the National Lung Cancer Screening Trial, where they found that there was a reduced lung cancer mortality in patients undergoing very low-dose CT screening. As a result of that trial, there are now lung cancer screening programs that are popping up everywhere, and they're generally covered. So if you look on the left, this is the population which I think we're talking about. We want somebody with moderate to severe already undergoing CT, so we don't have that perception of excess or additional testing. Number four, which is that low-dose CT is an extremely low radiation dose that demonstrates high correlation to gated coronary calcium scoring, or coronary calcium scoring can be performed in gated fashion at the time of low-dose CT. And then hence, because you're already undergoing CT, you don't get any, any additional radiation, and you don't incur any additional test costs. So this population, I think, fulfills many of the things that we're looking for. And then the question arises whether or not there are any discriminatory therapies for this population. What has been proposed is the first bullet point, different statin doses, high or low statin doses. But I think that becomes largely irrelevant in the context of the new AHA cholesterol guidelines. And so I think that perhaps the most important question is that if the clinical event rates of subjects with severely elevated coronary calcium scores either equals or exceeds that of patients who have experienced prior myocardial infarction, then should they not be treated as if they had prior myocardial infarction, i.e. with secondary prevention therapies as opposed to primary prevention therapies? So that sort of brings us to whether or not there are significant differences between primary versus secondary prevention therapies. And all of this is from the AHA guidelines. You can see that the primary prevention therapies are in the middle right here as it relates to all of the recommendations for lifestyle modifications and medications. And then on the right here are the secondary prevention therapies, and bolded in blue you can see the differences between primary and secondary prevention. Now the lipid management will change because of the new guidelines, but that initial treatment with beta blockers or ACE inhibitors for blood pressure control rather than hydrochlorothiazide or other antihypertensive medications, that metformin for initial therapy, low-dose aspirin for all, ACE inhibitors for all, beta blockers, cardiac rehab, depression screening, and subsequent treatment if people are depressed, and then a yearly influenza vaccine. So there are significant differences between the primary and the secondary prevention therapies, which brings us to the primary trial objective, which is to determine the clinical and the cost effectiveness of a coronary artery calcium scoring guided treatment strategy versus a usual care strategy for asymptomatic smokers undergoing lung cancer screening with a coronary artery calcium score that's greater than 400 or severely elevated. And the primary hypothesis of this study would be that asymptomatic smokers undergoing early lung cancer screening by low-dose CT with a severely elevated coronary calcium score, that secondary prevention measures as compared to primary prevention measures will reduce 3.75-year rates of a composite endpoint of cardiovascular death, non-fatal myocardial infarction, unstable angina requiring hospitalization, urgent coronary or peripheral arterial revascularization, resuscitated cardiac arrest, or non-fatal stroke. And so that brings us to the secondary and the tertiary hypotheses that in this population of people, that secondary prevention measures compared to primary prevention measures will result in reduced overall cardiovascular healthcare costs, improved quality of life, improved angina-specific quality of life, and reduced individual components of the primary composite endpoint, and reduced overall healthcare costs. So the study is an extremely simple study design. I think it's quote-unquote pragmatic, and it's strategy-driven rather than specific prescriptive therapies. It's an asymptomatic smoker undergoing low-dose CT for early lung cancer screening who's found to have a severely elevated coronary calcium score, who gets randomized to usual care, primary prevention strategy, or to secondary prevention according to the AHA ACC guidelines. This would be a directed care strategy. After that, you just leave the subjects alone and you let the doctor decide whatever the doctor wants to do. The inclusion criteria are similarly simple. The inclusion criteria are the smokers that are undergoing the trial operations would allow for study startup to occur during that half year while the protocol is being finalized, and then site qualification, recruitment, and randomization, and follow-up would occur during the next 4 years. The patient follow-up would allow for a minimum of 2.5 years and a maximum of 5.0 years, leading to an overall median of 3.75 years. The things that are depicted in yellow are the mechanistic studies, which I think are not prudent for this trial. I think bloods can be collected at the beginning of the trial and then simply stored for biobanking for later. I think that in the realm of these quote-unquote large pragmatic strategy trials, where large-scale trials cost an inordinate amount, that just simply keeping the bloods rather than trying to do everything under the sun is more prudent. The sample size calculations can vary depending on the estimated event rates, and you can get a range of estimated event rates depending on the studies that you look at. But if you assume a 20 to 25% reduction in the composite endpoint with an alpha of 5% and an 85% power with 5% loss to follow-up and a median of follow-up of 3.75 years, you can get a population study sample of anywhere between 3,000 and 6,000 people, and that's depending on, again, the event rates assumed. Certainly you can get down to a population of 3,500 to 4,000 patients. And so the feasibility of the study performance, I think, is high. I have spoken and communicated with Akron, as well as the who were the DCC and the CCC for the National Lung Cancer Screening Trial, and we're set to speak in early September. It sounds as if they're highly supportive of a trial like this, as well as looking at the prognostic utility of coronary calcium that's depicted on those 53,000 patients who are enrolled in the lung cancer screening trial. The National Lung Cancer Screening Trial sites, I think there were somewhere around 35 sites or so. They were all academic sites, and they managed to enroll 53,000 patients in 18 months. So I think that we can achieve and prove to reviewers that a 30-month accrual at 30 sites would be extremely feasible, which would equate to 4 subjects per site per month. The study's significance, I think, is that no prior large-scale study has assessed therapies to prevent cardiovascular disease events based upon coronary calcium scoring. At present, coronary calcium scoring is not generally clinically considered in low-dose CT lung cancer screening. Certainly at our site, we have tried to encourage, and I think are making headway to get those patients with coronary calcium referred to our cardiac prevention program. But even then, we see that it's not happening despite repeated encouragements. One thing I think that distinguishes this trial from prior proposed study designs is that there is a novel use of secondary prevention strategies in a population that mirrors or exceeds that of prior MI patients in a new population, i.e. asymptomatic smokers who do not meet traditional guidelines for secondary prevention, but who demonstrate excess cardiovascular disease risk. So I think that if we can perform a trial like this, we can establish potentially a new paradigm, not only for the smoking population, but for other asymptomatic patients who are at very high risk for cardiovascular disease events. And the study advantages, I think, in terms of grantsmanship and thinking of how a reviewer will look at it, is that we can leverage and piggyback on existing successful NIH trialist consortiums. Akron is the American College of Radiology Imaging Network that's supported by the National Institutes of Health. The National Lung Cancer Screening Trial was also sponsored by the NIH. The principal investigator of the National Lung Cancer Screening Trial is a woman named Denny Aberle, who's at UCLA, and she is the one that we're speaking to in early September. We're also speaking to the senior research, coordinator, but it's actually an MD who's a Dean Emeritus at the Medical University of South Carolina. And we've also spoken to Pam Woodard, who represents the cardiovascular lead at Akron. I think there will be a high efficiency of screening for trial enrollment given the success of the National Lung Cancer Screening Trial. And then we can guys decide as a group to include me to figure out before any grant is submitted or any study design is finalized. Namely, patients undergoing lung cancer screening generally undergo lower dose CT than calcium scoring, and they're all ungated. Certainly, I think it's possible to encourage national lung cancer screening sites to just either gate their CTs with low dose, gate their CTs with higher dose than near calcium scoring, or perform a separate query calcium score at the time of lung cancer screening. I think the third is not favorable, but the sites can actually just be encouraged to do whole lung gated cardiac CT for calcium scoring. I think the updated AHA cholesterol guidelines need to be considered in the context of primary versus secondary prevention. And in speaking with David Merritt, I think that we really need to consider the secondary prevention strategies that are expected to be beneficial, i.e. beta blocker for long duration of for patients who have not yet experienced an MI, and whether or not that is potentially beneficial or potentially harmful. And then dual antiplatelet therapy in patients who have not undergone coronary revascularization. And then there will obviously be, because there's severely elevated calcium score, patients who undergo ischemia testing or invasive testing based upon the calcium scoring or subsequent downstream testing findings. So how to curb that excess ischemia or invasive testing, or to just allow the MD discretion and let the doctor do whatever the doctor wants to do, which I think is probably a cleaner study and more generally applicable to the widespread use of calcium scoring in the general population. So that's what we've been thinking about thus far.
Great. Jim, thank you so much. We have a room full of, I'm sure, brain with questions that could be going back and forth. It's going to be hard for you to hear everyone, so I'm going to try to repeat the questions. Let's just start with PK. Raise his hand first.
Want to try the microphone?
Yeah.
Jim, an excellent protocol, very well thought out. The two questions I have, one is, what do you mean by primary prevention strategy versus secondary prevention strategy at a pragmatic level? How different would they be in a patient who has 400 calcium score or higher? That's number one. And number two, one of the limitations of this trial is that it doesn't address the issue of what do you do with the coronary calcium score of 0? That population, which is at least 50% of the asymptomatic population that undergoes screening. This is in no way to underestimate the significance of what you're proposing, but I see these as two potential problems.
Yeah, so let me try to answer them to the best of my ability. I think that I'm putting this slide up. I don't know if you can see it, but there are significant differences between this primary and secondary prevention strategy. The way I see it sort of pragmatically working out is that primary prevention should be done as the doctor sees fit. And so the doctor can be provided with the recommendations according to the guidelines, and then do whatever the doctor wants to do, including cholesterol lowering with statin medications as much as they feel like.
Matt has a question.
Hi, Jim. Great presentation, and I think very thought-provoking. I think if I'm reading body language correctly, there are a lot of questions with this group. So I'm going to just make a quick comment and then turn over the mic. My suggestion, and you and I talked about this a little bit, would be for the control group, which you're calling primary. I think that it would probably be ethically better to provide the patient and the treating physician with the results of the test and give them information about what the guidelines say. They should calculate a risk score just using the pooled cohort equation and leave it to physician discretion and patient choice on how to be treated. On the other hand, I think for the intervention group, rather than leaving it to MD discretion, if we're trying to prove whether we can reduce risk based on of hard outcomes based on a coronary calcium score, that we would try to be a little more directive than leaving it to physician and patient discretion, meaning that we might want to provide drug and have protocols in place for treatment and study coordinator perhaps to have follow-up visits, to have some more formal follow-up. Let me stop jabbering.
Okay, I'm going to go around with the...
I think that's a great point, and let me just make one comment. I think you're absolutely right, David. I think that the primary prevention, I think, yeah, they can get a card that delineates the guidelines and say usual care, and my sense is that that patient will either come once a year to see their doctor, may or may not see their cardiologist on a regular basis, and the care will likely be the standard of care, which I think we all believe is suboptimal. The secondary prevention care, I think that you're right, and this should be a directed care strategy. And if these people are acting like they've had prior MI, I think we should treat them and we should see them as if they've had prior MI. And so certainly twice a year, directed care, I think would be considered reasonable. And I think that they would get a closer follow-up to make sure that they are in fact adhering to the guidelines. And certainly free drug, I think, would go a long way in order to improve the compliance as well as the frequency of being seen by the doctor.
Thank you, Jim. So we have a number of questions, and instead of going this way, that way in the room, I'd like to start from there and get everybody's feedback. And since we start this trial discussion, which was supposed to be after lunch, so we're just going to get involved and do some of the talks, and then get to Sanjay's fun part after lunch. So I'm going to start with Tasneem, and as I'm walking to Tasneem, can you tell me if you've done this study, let's say we're done, and the results are great, and then boom, the question comes in, well, this is all about a smoker. The smokers have different genetic and, not genetic, vulnerable blood and thrombogenicity profiles and so on. Can we extrapolate to the asymptomatic population that are not smokers?
Yeah, I think that's a very good question. I think that we're not going to be able to perform a trial that looks at overall asymptomatic population-based screening. It's simply too large, and I think that the strategy of treatment is too difficult to try to figure out. I think low dose versus high dose stats is just, at least in my opinion, doesn't cut it, because I think that if we're going to think that people are at risk, that the new guidelines would argue that this low dose, high dose thing becomes largely irrelevant. I don't think we're ever going to be able to do a 30,000 patient study, and I think it sort of speaks to the same issue that ischemia faced. So the treatment of ischemia-guided coronary disease. I think if you look at the data, these patients represent 1 in 20 then to prove that it's widespread in all people, I think is something that's going to be virtually possible.
Remember, Jim, our problem with Framingham population that a lot of people say it's not representing U.S. It's probably representing half of the U.S. With smoker, being what 12% of people are smoking in the U.S. If we take a group that is only representing 12% of the population and extrapolate to the entire population, are we going to have problems?
I think we will. We'll have some pushback at the end of the trial if the secondary prevention strategy is successful. I think we're still going to get a lot of naysayers, but I think for the first time we'll be able to prove a mortality benefit or a MACE benefit, and that I think is one large step forward for calcium scoring.
Yeah, so you're saying it's a baby step. The alternative is a lot more difficult and challenging and unfeasible, and so that's what your approach is. Okay, I'm right at the beginning. We're just going to go quickly through the panel and take questions, but please make your answers short.
Okay.
Jim, thank you for your very well thought of protocol. I did not hear any mention of smoking cessation and an effort to do that. As a reviewer, I might want you to focus more on a measure that alone could actually be equal to all the secondary prevention therapy that you're wanting to give. So if you could please hold that thought. And the second thing is your sample size calculation of 3 to 6,000 was based on a 25% event reduction. Was that derived from what was the basis of that assumption? Because if you have smoking population with a coronary calcium of more than 400, I think the physicians are going to be more aggressive than is listed here under primary care, including an LDL of less than 70 and maybe even aspirin. And then the third is consideration for bupropion in patients who are depressed, because that has also been shown to cause smoking cessation.
Yes, I think there are three questions. I'll answer them quickly. I think you're right. Smoking cessation should be more aggressive in the secondary prevention group. I think if they are seen more frequently, i.e. twice as much, that they can at least be followed. I think the use of Wellbutrin is good. I think that should be the first line agent for depression treatment. And then in terms of, there was one more question, I'm sorry, in the middle.
The sample size.
Yeah, how did you calculate sample size?
Yeah, so I calculated sample size on 20% reduction, 25% reduction, and then using a host of assumptions on event rates between different studies. We can get to 5% per year event rates if we make the MACE composite more general. We can get to a 20% reduction in events also with a reasonable sample size around 4,000. I think 20 or 25% because I think that not only to be statistically significant but to be clinically relevant, that we have to do something. I think when we say we're going to do a 7% reduction, that nobody will believe us, and in addition to that, it's going to severely increase the sample size.
Okay. Obviously, all of these subjects are, going to be discussed in the study design. We're not doing the whole thing.
So I wanted to first commend you for trying to come up with a very streamlined design in an era where clinical studies are ridiculously expensive. So this was a very nice approach. I think the three things I would say is just acknowledge up front the same criticisms that people say about Jupiter, where we don't know whether it's the CRP or something else. We're not going to know whether it has anything to do with CAC, right? We are selecting people based on a coronary score, and then they're going to be triaged to primary or secondary prevention. Some would argue that smokers at high risk or undergoing scans would be at risk to begin with. And I think that's a criticism that one can deal with. The other strategy is to have another group where you just do primary and secondary prevention. The study gets very big, it's not CAC oriented, but just to acknowledge it. The second thing is, we've already talked a bit about this, but it's going to be a strategy. So we don't know which of the therapies is actually the one that leads to the reduction. Again, that's fine, but just to acknowledge that that's something that would come up. And then to really tease out this difference between primary and secondary prevention treatment, I think we heard earlier that someone with a CAC score of over 400 in the primary prevention group may actually be treated pretty aggressively. And the question will be how rigid I think as David was saying, one wants to be about the two different treatment strategies. And if you really want to differentiate them, do you have usual care and then a polypill or some component where you are controlling what therapies the patients are getting so that there truly is a difference in strategies, so that there's not regression to the mean where the two groups are treated in the same way. But other than that, I think it's clever.
Thank you. Let me just make two comments. Like the first is that the primary prevention, all that I bottom dollar that those patients get pretty crummy care. And I think that if you look at the way people practice, I don't think that they're very aggressive. And I think that this group represents the vanguard of people who are treating atherosclerosis appropriately, but most people don't. And so I think that, this whole concept that David mentioned of just usual care to let the doctor do whatever the doctor wants to do, it's going to result in pretty crummy care. The second thing that I'll say is that the reason I thought that this trial design might resonate with reviewers so that we can actually get it funded is that it's so easy to understand, right? It's just primary versus secondary. That's something that just is easy to remember, and the secondary is very easy to argue that the event rates are similar to those at MMI, so they should be treated like that. So that's the rationale, part of the rationale of trying to do this. And then the third rationale is simply the low versus high dose statin that I think just doesn't cut it.
Okay, thank you. So this, the first concern that you had, what is it to do with CACs? This is just the effective therapy. How do you answer that?
I think that it's a baseline high CAC. Like that's who you're treating, right? Everybody else is the same. Albeit they're smokers, but everybody is a smoker with high CAC. And so you're just treating that. I don't think anybody's going to argue that treatment with ACE inhibitors is reducing lung cancer. So I think that it's a logical assumption that we're treating cardiovascular disease, given that our intervention is secondary prevention of cardiovascular disease.
Okay, let's hear from Sameer.
James, again, I'll echo, just thought that this really is a clever design, and just so you know, you are among friends. And I want to just sort of maybe one way to approach this, whether this is coronary calcium score or not, I think is you would have information about the risk factor distribution from the National Lung Cancer Screening Program. We didn't quite see what that looks like for folks who are in this study, so maybe that would be useful information for everybody to see. I have two additional comments. One was, it wasn't after, maybe you have this in the fuller sort of fleshed out protocol, is the issue of how you were going to curb testing down the road. I didn't quite see that. I'm not sure how you're going to control physician behavior once they see the 400 calcium score. And the last thing I wanted to say is that I wasn't quite convinced of the utility of including hospitalization for unstable angina and also the testing regarding angina severity. It feels like it would be an exercise which may not yield as much at the end of the day.
Yeah, no, I agree with you. I don't think that we should recommend downstream ischemia testing or downstream invasive angiography or CT angiography or whatever. I think we should just let the doctor do what the doctor does. And I will contend once again, at least from what I observe locally, and we have 100 cardiologists admitting to Cornell, I don't think people get treated very well. And so I don't believe that CAT score of 400 is going to precipitate a lot. I think that most people don't know what to do with the coronary calcium score of 400, and they're just going to look at primary prevention and say, okay, I do a pretty good job, and I'll give you a statin and have a nice day. So I think that there is the potential to really reduce that.
Got it. Thank you.
Yeah, that's assuming that Sheikh just stays quiet and doesn't do the community education and all the things that we're doing. Moving to Henrik, Jim.
Yeah, I'm just going to follow a little bit on the same line, because I would assume that you're going to have to patient and doctors basically to tell what CAC score of 400 actually means. So wouldn't you expect crossovers? I would. And then I have just one comment to one of your endpoints, which was the emergent intervention. I would just advise not to have emergent carotid intervention, because that's most often for asymptomatic disease, which is not a good endpoint.
Okay, I think that's a very good point. but I tried to make the onset point as generalized as possible, so that we could increase the event rate. Otherwise, I honestly think that in the era of promise and ischemia, that the NIH is loath to fund another very large scale treatment trial or imaging-based trial. And so, I think going in with a 3,200 sample size, and a budget of 18 million is not unreasonable, as opposed to the 100 million, 120 million ischemia trial. So I tried to make it as inclusive as possible, simply to reduce the sample size.
Okay, we're going around. Question?
Yeah.
Mike McConnell.
Hey, Jim. Good talking to you. So I guess where I struggle is, I really think it's interesting to look at the primary prevention versus secondary prevention. Obviously, there is an issue with secondary prevention, takes into account someone's had a myocardial infarction. You could argue some of the drugs are targeted to the myocardial aspect. But kind of aside from that issue, what I worry about is you're mostly randomizing people to bad care versus good care if you're going to let the primary prevention group be kind of, undirected. And so I would look at this paper at the end and I'd say good care wins over bad care, not secondary prevention wins over primary prevention. So I would argue to do great primary prevention versus great secondary prevention to prove the hypothesis.
Yeah, I think you and David might have a different view. I share both of your views. As a purist, I'd love to see true good primary versus true good secondary prevention, but I think we won't. I think that we need to be scientifically honest, and I think that we also need to try to design a trial that will win. And I think the primary / usual care, I think it will ensure that we win on this trial. By win, I mean having a positive outcome. But as a purist, I'd love to see the good primary versus good secondary. I just think that that's going to regress towards the mean, and we're going to have a negative trial.
Just to comment on top, Sanjay mentioned this Ravinska trial in Europe, and interestingly enough, they have a control group in that where it's basically almost a do-nothing usual care as a third arm. So there is the possibility of undirected care versus directed primary care versus directed secondary care, but that becomes a much bigger trial and harder to...
No, I like that trial, and we definitely considered having a third arm. It increases the sample size, and I think you make a compelling point that you can do primary versus secondary versus what they're doing now, the standard of care, which is ignoring the declaring calcium, so they don't even need to report it. Then invariably you'll win, and invariably you will figure out which one is more effective, primary versus secondary. You'll just increase your sample size by a third, which I think is definitely something we should discuss, because I like that idea. Right now they are ignoring the calcium in the coronaries, and that is something that we should prove that they shouldn't.
I just wanted to, I wanted to second your point about having excellent primary prevention, because in the PCSK9 space now, there's a lot of cynicism around the Odyssey program and what happened with the care arm. So I think there is more scrutiny in your comparative. So to think about it up front, make it robust is good.
Yeah, my only concern with ignoring and just letting them do whatever they want is that a reviewer will say, well, hey, that's not fair. They have that resources and you're not treating it. Our argument would be you have no idea whether or not that treatment actually, but I do wonder whether or not there'll be sufficient equipoise to just ignore the calcium results altogether. But I like the idea. That's, to me, the trial to do.
Hi, Jim. That's a beautiful presentation. It's Dan. And I just wanted to bring up a completely naive just question. Since these patients are all undergoing the scanning, and the only cost, I think, is the additional, there are costs, but there are no extra costs of testing. I'm just wondering whether increasing the sample size could be feasible, and then just with that, would it be possible to do in these high-risk smokers a study of calcium scanning versus no calcium scanning, giving optimal care to the way in which smokers would generally be treated, and then having prescribed therapies for the patients who've undergone calcium scanning according to their degree of calcification?
I think that's even better, but I just worry that the sample size will grow considerably. 80% of the patients who, at least in our center, have either none or mild coronary calcium. So all of a sudden you would probably increase your sample size by more than fourfold. So that was my concern. I felt like I felt like there's a peer trial that answers the question, and that is a trial that you can actually do. And I felt like you cannot do a trial that is 12,000, 15,000, 30,000 babies. I mean, maybe you guys can, but I couldn't envision a sense of a source of funding that for that, which that would be possible.
Thanks. We're going to, you already had your question.
Oh, yeah, but you asked me to be moderator, so I'm taking license, and I'm going to ask another. I share the concern that's been expressed, Jim, about what is the value of the coronary calcium. If the purpose of doing a trial is to show that doing calcium screening is of value, I'm not sure that this design gets to it. What about and I did a quick calculation using the ASCD risk estimator. If you take a 55-year-old man whose only other risk factor is smoking, the risk turns out to be 7.5%, which means that the guidelines would recommend that they be treated with what you're calling secondary prevention, or at least they'd be started on a statin. It might be moderate intensity. Mike is going to...
Well, it is secondary prevention, post-MI secondary prevention.
Right.
It's very different than that you already think you have an after.
Okay, but just take this argument along a moment. It's going to require by guidelines that everybody be treated, or you have the discussion with the patient that they should be started on a statin. I'm wondering if there were enough patients who are screened at these for lung cancer who have a calcium score of 0, and then look at calcium score of 0 and the same treatment as a calcium score of greater than 300 or 400 to see if that makes a difference in terms of outcomes. Because the patients with a calcium score of 0 shouldn't have a very high event rate based on all the evidence that we know. So that's my question.
And so my guess is, and I don't know, the National Lung Cancer Screening Trial did not publish cause-specific mortality, and the majority of the deaths were non-lung cancer screening deaths. I don't know how many were cardiovascular. I think that they will share that information with us. I think they will also share the prognosis of those patients with no calcium versus, or rather, I think they'll share the images with us if somebody's willing to go through 53,000 images. But my concern again is that these are people who are just not going to have events. They're just not. And so now we're studying a population of people who would not benefit from statin therapy, which is good. But the sample size again is going to go up so considerably. And I think if the new guideline, if we just say, hey, low versus high statins, which is what we're resting for this whole conversation, then we're going to lose that trial. It's just not going to be a positive trial, because once you're on a statin, people are going to drive that LDL down. I think that the primary prevention, when you say usual care, we're not going to see LDL to 65. We're just not. I would be surprised if we do. And if we do, then maybe, there's no difference between treating high calcium with secondary versus primary prevention medicines. But the only, you're right, we're not testing the hypothesis of whether or not doing a coronary calcium scan can save a life, but we're testing the hypothesis that treating, visualizing I wish we can actually get that trial done. I think that Phil Greenland proved it, right? He went back to NHLBI twice, and they said no, and I understand why. That's a $100 million trial.
Jim, I'm not sure if I was clear with my suggestion, and that is to compare, for the two groups to be one with a score of 0, or you could say a low score, versus a high score.
So Jim, we're going to have a lot of discussions after we hang up with you, and we will reflect the summary. Some of these questions, of course, are going to create more questions, and we already run out of time. But Robert Superfo has a quick question.
So Jim, this is Robert. Like everybody else, I want to say thank you for all the work you did. It takes a lot of time and energy. A couple issues. I'm concerned that the etiology of coronary events in smokers could be different than the standard population, and therefore that's the issue of transferability. And I think if we're looking for an investigation that proves that CAC scoring or coronary calcification is clinically useful, we need to answer a clinical question that physicians are asking in a group that they see frequently. So I think it would be informative to do power calcs on, let's say, a group of people with positive family histories, or a group of people whose primary relative had a positive CAC score, or maybe like Howard Hodis is doing in perimenopausal women. So if we did power calcs in those groups, do you think it would be any different than the standard population? And could we get to a small enough sample size to actually be useful?
Yeah, I think that those are great questions. And if you ask me which one scientifically I'm most interested in, if I could pick a population, it would be that of premature coronary heart disease. Just personally, I have an interest in that. That population of people, I think, and the postmenopausal are hard to find. And by hard to find, I mean you're going to have to scan a lot of them to get one of them. And my guess is you have to scan 10 to get 2. And then I think you get a lot of pushback from the reviewers that it's going to cost a lot. And that's the whole point of calcium scoring, is that it's going to cost a lot. That's why we shouldn't cover it. And in addition to that, I think you'll get pushback on the radiation and the extra testing. So those were my rationale. It may be poor rationale, but it was my rationale.
No, it makes a lot of sense.
Okay, thank you, Jim. We're going to go to Nathan Wong.
Yeah, hi Jim, this is Nathan. Hi, it's a very interesting, I think you have a very interesting design, and it's great to see how you propose this to actually piggyback on the lung cancer trial. I just had one pretty simple question. Since the actually number needed to treat is very, very good, even for people with calcium scores of 100 or higher, have you considered using that cut point, which may, number one, increase your accrual rate, and also number two, you might not find everybody so aggressively perhaps treated as you would if you limited your inclusion to those with actually 400 or higher?
Yeah, no, that's a good question, Nathan. I think that, right now, I think we can make contend that the actual event rates are going to be around 5% per year if we include a composite endpoint that's generally more inclusive than less inclusive. And that gives us the sample size between 3,000 and 4,000. If we start to go to 100 or 200, then what I think we're going to see is event rates that are around 2.5%. If we get to 2.5% for a 3.75-year follow, I think we're going to look at a sample size of around 10,000 or so. So somewhere between 8,000 and 10,000. So I think then it becomes a very expensive trial, which is why we said that we would have the best chance at winning if we started with a calcium score that was severely elevated. And to be very honest with you, I think we're going to get the biggest bang for our buck for pushing LDL down with a statin, particularly
Okay, so the next question comes from Sanjay Paul.
Jim, very, very nice presentation. I understand that reconciling trial feasibility and clinically relevant trial is very challenging, and I think you have come up with some clever ways of reconciling the two. I think you probably need to focus more on the treatment contrast. How do you justify the treatment contrast? It seems to me that you are artificially introducing a contrast that may not exist in clinical practice, between the primary prevention and secondary prevention. That's one criticism that we have to be prepared to address. I mean, if you look at the contrast between less intensive dose of statin versus more intensive dose of statin, it is only about 16% risk reduction. And that's probably where the difference would be in the real world, not 25%. And as you correctly pointed out, if you reduce it to 16%, the sample size is going to go up by 4-fold. So conceptually, it's a very, very appealing design. But it seems to me that if the way you're introducing this into contrast is a self-fulfilling prophecy, it may adversely impact the clinical relevance of what you're trying to achieve.
Yeah, no, I think that's very much it. But I'll just say, I guess, 2 points to that. I think that you're absolutely right. Like the decent reduction in LDL versus really intensive reduction of LDL isn't going to give us a 25% risk reduction, and it may be more prudent to go for somewhere less than 20% risk reduction, or to try to find a better way to reduce risk. I think we're going to get some benefit from the low dose aspirin, because I think that a lot of the people in primary prevention aren't going to get that at all. And I think as long as these patients don't bleed, we're going to see pretty good risk reduction. I think that in terms of your comments about, you're contrasting something that's really sort of not generally thought of, I hope we are, because I just don't, well, I might be wrong, and you guys might disagree with me, but I don't like the trial low dose versus high dose statin. It just doesn't make sense to me. If I'm going to treat somebody with a statin, I'm going to treat somebody with a statin. And to me, that's a binary issue, getting as low as I can. I like the polypill. I really like that idea a lot. My issue with that, and the reason I didn't put that, is because I think that one still people are pushing back on too. So if we go after a calcium scoring, which people push back on, and a polypill that people push back on, I just felt like for reviewers, that would be a tough argument. And this one, just given the high event rates that near or close to mine, I felt like it was something that could resonate with reviewers. So I recognize your points, and I think that they're extremely well taken. I just tried to figure out a design that somebody would actually fund.
Yeah, man, I just want to remind you that the rosy predictions for modeling exercises of polypill have not come to bear fruit. If Mark Huffman published a pooled analysis of all the secondary prevention trials in the November JAMA paper last year, and what he observed was that there was an imbalance in cardiovascular events not favoring the polypill. In contrast to the 60 to 80% risk reduction that was projected in the modeling exercise. So that's why I think you need to really rethink the contrast that you're introducing.
Yeah, I told, so we bandied about this design for a while, and, people have pushed back on the design much in the way for the issues that you guys have raised. And I said, I care about those issues, and I want this trial to be positive because I believe that hypothesis, which is why it's the primary hypothesis. But I care as much about the pure trial and trying to see that it can be proven positive, but I care more that we can actually do it. And so I tried to come up with a trial design that was feasible and could be funded. So I recognize that there are issues with this trial, and that this trial may be negative, but will never, to my eye, unless you guys have funding sources that I don't have access to, but I just get to a $15 doctor. I just think that those days of ischemia are long gone. David Barron has taken all of NIH's money and kept it for himself.
Okay, Jim, thank you so much. I think you made very clear the practicality of your proposal versus the needed answer that we as society are after, and that is whether coronary calcium primary prevention can save lives. And that's what our naysayers want us to show. You're saying this is a baby step, will take some pressure off, and then opens the way to go forward. We're going to conclude our session here and have Phil Greenland's study View be presented by Matt after we hear the counter argument that why bother testing and just $3 based on St. J's proposal. So again, thank you, Jim, for making yourself available, and we appreciate and look forward to continuing discussion with you.
Okay, I really appreciate your time. Have a wonderful day, guys. Thank you again.
Thank you. So everybody, we're going to take a break,
Thank you.
grab lunch, and have enough energy to fight St. J.
It's a rhetorical exercise.
That's it.